My talk was embedded in that session on localized disease and trends and controversies. And I was asked to focus on risk stratification tools and any advances in that space. And I presented through the lens of my role as the NRG GU Translational Science Chair, where we've been trying to increase precision medicine concepts in the GU radiation oncology space. So if I was going to summarize my talk, I would say really there's three main points. The first is, and I used the often quoted model of stage migration. There's a quote from Will Rogers with regards to migration of the Okies, who are, it was during the Great Depression, of folks moving from Oklahoma to California, and how rearranging these populations increases, it's a joke, but average IQs of these individuals in Oklahoma and California. And that is really a great example of what we're trying to do with risk stratification, which is essentially, so the first point is trying to use tools, clinical and increasingly more genomic and artificial intelligence tools to increase the ability to precision risk stratify patients into correct groups. And that in and of itself will increase the average outcomes of patients. But something that I wanted to highlight to folks is that even though we know stage migration, which folks are familiar with, will increase average outcomes of groups, it also does benefit the individual plight of a patient within those groups, because the patients that we've reclassified are now more or less likely to receive the appropriate treatment. So for patients who are reclassified into lower risk groups, they're less likely to be overtreated. Patients reclassified into higher risk groups more likely to receive the more intense or appropriate treatment, and much less likely to be undertreated. So that was one point. And the second is just some of the advances in our NRG translational science group and how we approach that topic of risk classification now. So now in the present, we tend to use more multiparametric platforms like whole transcriptome profiling. We tend to use platforms that are CAP-CLIA certified to allow us to implement these findings directly into the clinic. And third, we've formed academic industrial partnerships with groups to accelerate our progress. And so I used as an example the Decipher classifier, which is a 22 gene genomic test that has been validated now many times over to be prognostic for distant metastasis and prostate cancer specific survival in the localized space, and how we're incorporating that into our first in field genomic integral biomarker driven clinical trials, namely GU009 and GU010, which are trials in the high risk localized and intermediate risk localized space. And these are utilizing, again, a genomic classifier to stratify patients. And hopefully what the hope is that we'll be able to appropriately treat patients of a given risk group with either less intense treatment, so de-intensification, or more intense treatment. And then the final part of my talk was some of our future work looking at digital pathology and artificial intelligence, or AI, and our collaborations with the Artera company, and how we're using some of their very state-of-the-art technology to, again, help us risk stratify patients in the localized prostate cancer space. And we believe that we have our first in class, again, predictive biomarker in localized prostate cancer to determine patients who can, who should best receive hormonal therapy using this Artera artificial intelligence biomarker tool.